So,
But
Jim, I was wondering what you remember about when you first met me, and when I know that study that began in January 1983 was the main first study, but I don't remember too much about our interaction before that. I came to Hopkins in '72. I joined the faculty in '77. Do you have some? When did you come, or what was your?
It was just about. I started at the beginning in January '78, so we
Right.
arrived there at the same time, and
Right.
we must have been going back and forth about kidney biopsies from that time on.
Right.
Obviously, the only thing we were doing at that point was renal
Yeah,
transplantation.
but you did your own renal biopsies. Is that right? Did you physically do them?
we always did the renal biopsies.
Yeah.
And the story about, I was remembering the other night thinking about this, when I first started, the training I had meant that we would take the patient to the outpatient surgery area and anesthetize an area over the transplant,
Mhm.
dig down through the scar tissue and everything, and take a little, manually remove by scalpel a little bit of the
Wow.
tissue for the biopsy, and it always went fine. I mean,
Right.
and then close it back up. And we had a resident who had had some background experience, maybe as an advanced medical student or an intern, in I think a hospital in Texas, where they were just doing a percutaneous kidney biopsy, and this was somebody that I've learned to learn from the residents, and this was somebody
Sure,
I trusted, and
I do the same thing.
I felt that
Yeah.
we could handle whatever happened, so he was interested in showing me, and I remember he just took the True Cut needle and numbed things down, and took
Right.
the True Cut needle and just plunked it down in, and I remember he looked at me and like that, and there wasn't anything wrong, and so he went ka-chunk, and the
Right.
True Cut came out, and that was the kidney biopsy, and I always did it after that
Yeah,
way.
wow,
That was
cool.
probably 2 or 3 years after I got to Hopkins. So, and I'm sure we were talking over kidney biopsies for a while.
Right, right. So with the immunofluorescence piece, what we used to do is freeze that in a jar on a chuck for cutting frozen sections, and those frozen jars were quite fragile. So I developed some, spectacular cuts on my hands when the jar would fracture. That was sort of an interesting feature of those times.
That could be a technological identification. Do you know the sign? Do you know that sign? You can't see it well on the camera.
No.
I have a little scar right here, and that is the mark of the chemist. Because anybody who's put a lot of glass rods into a lot of rubber stoppers setting up a chemical apparatus
Right.
has broken one and scarred their hand.
Yeah,
So
yeah,
somebody
wow.
wrote one time that
Yeah.
that's how chemists can recognize each other. So the same thing with pathologists.
Right,
And
yes. Yeah, and so I remember one time this happened, and Lorraine Rackeson's room where she was training and my office were just adjacent. It was a hallway door. Like, she never opened the door for me. I wasn't part of the deal. But it was apparent that I was holding one hand with the other, and something happened. He said, "Would you like me to open the door?" I said, "Yes." So yeah, there were some risks of the way we handled kidney biopsies that these guys don't have to worry about now. So, when did you first get the idea of doing protocol biopsies? Was it related to the cyclosporin trial, which would have been around that time?
It certainly was in the era of cyclosporin, at a time when really we had, it was a wonderful time to be in transplantation because the results suddenly got so much better when you started using that drug. Obviously, nothing else had changed, the operation was the same and everything. But there were more issues that were sort of questionable, and it was less, prior to cyclosporin, acute rejection was often pretty obvious because it was such an inflammatory response. But after cyclosporin, it was more questionable. So the answer to your question is definitely very clear in my mind. I remember a time when you and I were looking at a kidney biopsy in a patient who was fairly, maybe a month or two out, I don't remember, who had been doing well, and then there was some question about the renal function and had a biopsy for cause. And we looked at the biopsy and you said, well, there are some lymphocytes here. And I said, yes, I see. Moderate. It wasn't a big infiltrate, but it was infiltrate there. And then you said, but there's no rejection. And I said, what do you mean? Because
what are
I
those
think
cells doing there?
every surgeon, maybe not with the innate wisdom of the pathologist, but every surgeon felt that if there was a lymphocyte present in the tissue, that represented rejection. So we discussed it, I think, amicably, although I still had my opinion, but we decided to do the protocol biopsies at 1 month and at 1 year. And it was a very exciting study because it clearly showed that I was wrong and it didn't necessarily mean rejection.
Yeah. Well, I remember, as a young person giving talks at meetings, I never had a standing room only audience until doing that. And you sort of indicated you thought this would keep on happening. I thought, wow, that'll be really great if every meeting that I go to in the future there are never enough seats for people to hear me talk. So that was an exciting. It was sort of a game changer, I guess, in terms of my feeling about the impact of what we were doing. I used to feel desperate for anyone to take an interest in the research that I was doing. It never occurred to me that there would be a scenario where I didn't have to feel desperate. That this was something so important.
Well, it was a very powerful insight, but I presented perhaps just one time at a mainly surgical meeting, and the data were there. I mean, nobody could argue with you. And it was very new, but of course this was again early in the cyclosporin era, where that sort of situation was more likely to require the kind of interpretation that eventually gave rise to the Banff criteria. The only exception in terms of precedent that I can remember, and I think it was about the same time, they had some protocol biopsies at the University of Minnesota,
Right.
and mostly probably from the surgical service influence, they had some biopsies. They hadn't done it in the more standardized way that we did, but they had some biopsies that had some lymphocytes in them, and the patients had done well, and so they took the only conclusion from that they, as surgeons, I guess, could do, and that is it must be a sign of cyclosporin toxicity. And of course that it didn't pan out, but our understanding about what's needed in order to make the diagnosis of rejection was easier to be convincing about because we had a set standardized and larger numbers of these cases.
So, the Minnesota side of this was also important because of Minnesota ALG, and it seemed like patients receiving that had sort of a quieter background, that they weren't as inflamed generally, like you had improved the environment somehow by giving Minnesota ALG, just in general. It wasn't, it's a more quiescent, less inflamed background. So then we began that study then in January of '83. I'd already kind of started looking at chairmanships there. I looked at London, Ontario, and so on, and a number of places where I knew these weren't right for me. And then one day, one of our senior pathologists walked into the library where I was and just happened to mention this place here with this beautiful atrium, and this building had just been built. So it's one of the most expensive medical buildings, I think, in the world at that time, and quite exciting. So then when I moved here, I became very interested in importing all of my friends. I wanted to import you. I wanted to import Lorraine Rackison, get all you guys up here. And the moment that I recall where I felt so inadequate is when you came up here to look at the chairmanship in surgery. And in the midst of the interviews and so on, you asked me something detailed about the Canadian healthcare system that you didn't understand. And I realized I didn't understand it either, and I was no help to you at all, and I thought, darn, if only I had some magical insights, that would have been good. But the two countries are different. Now, you've written a book on the single payer system. With skipping ahead to 2017, what are your feelings? Does Canada have everything right, or there certainly are. There are much longer wait times here for many things. If a patient wants something done, and to get the system to pay for it, they will wait much longer here. But otherwise, I think the system is probably in many ways better than the U.S. But what is your...
Well, to address the Canadian system, it's so much better than most developed countries in the world have systems that are so much better than the United States that I don't think any reasonable comparison it puts the U.S. in better shape. And in particular, as far as waiting times go, it's so important to remember that with 20 or more million people with no insurance, and many other people with dodgy insurance.
It isn't a matter of wait time, they just can't
Well, if you're calculating it, you've got a bunch of infinities to use in the States. And so waiting time, and moreover, now I know more about the situation in Ontario than in Alberta, say, but waiting times is in a national system. If you have that kind of problem, you know it, you can define it, and you can work on it, and that's what's being done. And when I talk to Canadians, they are not impressed with the waiting time. I mean, what they tell me, and I've had this more than once, if you get sick, they take care of you, and they don't send you a bill. Now, they know nothing about waiting time. And
it's cool.
So
something we can be proud of.
You can be proud of it. It is not a perfect system. It has the incentives for sort of hospital cost control versus the fee-for-service doctor's status is a difficult tension, and so I think that this book that I wrote called Talking About Single Payer has some lessons in it for maybe every other country. After all, most countries, at least by around the time the U.S. put Medicare into place in 1965, had their systems then. And medicine has changed so remarkably since then that we have an advantage in the U.S. if we would get going on it to put in a system that would make much more sense in 2017, and Canada would need to catch up ideally. And so my view, and in fact in the States it's often touted as Medicare for all, and then people realize that you should say improved Medicare for all, but really, even though Medicare is so popular in the United States, it is far from perfect. Overuse has been documented in Medicare, which is costly and dangerous to patients, and so forth. So the comparison is very powerfully in Canada's favor.
Mm-hmm. Yeah. Well, that's fascinating. So, what have been your thoughts about the Banff meetings, the Banff process? I think you would have a unique viewpoint in a way, in that you actually haven't come to very many of the meetings, right? So you were part of the start of it. You're crucial to Banff beginning, but you have a kind of objective viewpoint because you're not like embedded in Banff. Your career hasn't been dependent upon Banff. What we feel now is many people, their future within transplant medicine is so tied to Banff, and you really haven't been in that circumstance. You could kind of look on from afar.
Yeah, it's definitely played a huge role in the part of anybody taking care of, developed any kind of transplant anywhere in the world. So I'm part of that. But as cyclosporin really, the benefits began to be realized and take effect, it created much more of an opportunity for an expanded care team.
Mm-hmm.
When I started in '78, it was mainly transplant surgeons and histocompatibility people.
Mm-hmm.
Not by any means totally, but what changed was a much greater involvement in post-transplant care, since the patients were doing better and they had transplants being maintained, for nephrologists and others taking care of their more long-term decisions. And the surgical team at Hopkins, and I think in most places, remained very involved, even in late decisions about their transplant recipients. But it was much more in the hands of a larger group. And certainly at Hopkins, we had very good pathologists, and we hadn't managed to get up to Banff or to Alberta, and nephrologists who became rapidly much more involved, and it made sense for them to be part of that. It wasn't a scientific interest for me, and being, as everybody is, plenty busy clinically in other ways, it didn't seem like it was an avenue that I wanted to take, although I might have, but it certainly was a dominant thing in our sitting around in the discussions and what the biopsy showed. I would highlight one thing that I think was particularly important was when we began to look more seriously at antibody-mediated rejection. I think that was that ability to know what we could say and know what we didn't know for those tough cases was, to me, one of the things that the Banff criteria were golden for.
Right. Now, when you went to the NIH, I was aware that whatever happened there was quite positive, and that many people who I would later encounter, I would mention your name, and they would say just wonderful things. I don't know how that happened, but it seemed like many people were positively impacted by your role there. So do you want to?
Well, that's great to hear. I think just a disclaimer, and that is that I was at the NIH, but it was in the mid-'70s, and that was a great time. But that, don't think was what you're talking about, because at the end of my career, I did take 5 years to be in the federal government as director of the Division of Transplantation, which has the contracts for UNOS and the SRTR, and also has a the National Bone Marrow Registry program.
Right.
Wonderful people to work with, and we had a fair amount of intersection with FDA and CDC and others, but the overall national programs in each of those areas were under our division of transplantation. And we worked very hard and successfully with improving organ donation. We worked with the FDA for rules about vascularized composite allografts, which it was clear more and more that the value to a patient was well offset the risks, which were very real, of putting in any organ and then immunosuppressing them. But the issue of quality of life began to be much more clear. So that was the time that I really had a chance to participate at the national level that way, and that was a very wonderful time. And I think it was the things we did that made sense. Support for living donor families, expenses to travel and so forth. That was a very much of a team effort for people in the field and people in the government. It was not anything I did on my own.
Yeah. Well, I guess what I feel is that I've always respected politics and medical politics, and in a sense a lot of what you've done and what I've done is in that realm. And it's kind of a family thing. My wife has many politician friends, and she's politically active. So how do you feel about that? Is politics a sort of dirty word for you, or you think politicians are capable of making the world better?
Well, I guess for the purposes of this video, which may be around for a while, I'd emphasize that I'm talking as somebody from the U.S. in 2017. So
right.
That it sort of probably generates a bias, but let's not go down that road. I think the field of transplantation, in a way, as it developed, particularly in the U.S., and somewhat the same in many countries, it is a very good answer to that question, because only with the kinds of negotiations that really took place to put the organ allocation rules in place would we have a satisfactory process about deciding when an organ becomes available, which patient it should go in. And these are high stakes questions, because if it goes to one center, it doesn't go to another center, with all of the issues of where the financial reward is, as well as where the moral obligation to patients would be. And I will tell anybody that I have ideas about how I think things could be done even a little better than we're doing them in the organ procurement and transplant network in the United States right now. But it is far and away the best way it could be done. Doctors and nurses and other specialists and people with an interest in it working together to make the rules and oversee the national data system to make sure that things are going right, and in the case of a program that's having trouble, to highlight that and decide what to do, and so on. And so that's a very political process, and yet it's based on a need to do a humanitarian and technically effective medical care. So that sort of answers the question from my point of view, and in fact, the ideas I have for a universal health care system, a single payer system in the United States, are based partly on the way the mechanism that I just described works, both as a way to think about how it might happen and a proof that it could happen.
Yeah, yes. Well, I want to thank you very much for talking with me today. I'm kind of jointly proud that both of us are involved very much in research oriented around future new innovations, and we're not just resting on our laurels, and so it's taken some time to. I mean, we spent a lot of time talking during this visit without really talking about the past very much at all, and I think both of us are quite more oriented toward the future.
Well, yeah, it pays to remember the past, and it's fun to remember the past, but it's also fun to be thinking about the kinds of things you
Yeah. And what I found very surprising and wonderful is in this paper that has just been accepted by AJT of tissue engineering pathology, that there were 7 authors, and toward the end there were many instances where you and I were the only ones actually working on it, and that was kind of wonderful because we've been working together for
Well, that was a great pleasure,
so
and
long.
of course it's because we go back so far that was part of the reason that I took that particular interest. I have to also stipulate that as probably one of the more elder people on that list of authors, I probably had more time when something came through
Sure,
to go over
sure.
the text,
Yeah.
out of fairness to the others who are much more still working for a living.
Right, no, they're
So
they're
that was an
mid,
opportunity for me.
career with
Yeah.
lots of
Yeah.
pressures and other people expecting them to do things. So but actually Astik Petrosyan was the other person who was quite active. She is a young person, I think in her late 20s, and so the 3 of us were sort of the
Well.
powerhouse finalizing that paper that really represents something that I've been at least talking about for 6 years. So it's a culmination of a very long project. So anyway, thanks for talking with me today, and I think that's probably a wrap. Thanks. Okay.